Good evening and welcome to the November 18th General Board Meeting of the Oakland Community Health Network. At this time, if you are able, please rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. The roll call of the members, please.
Mr. Young.
Here.
Mr. Furman.
Present.
Dr. Giles. Pastor Jones.
Present.
Dr. Guadalupe. Here. Ms. Woodruff.
Here.
Dr. Hans. Ms. Newman. Ms. Root. Mr. Smith.
Here.
Mr. Cowan.
Present.
Did I miss someone? Pat, did I miss? No? You have a quorum.
Thank you. Next, we have approval of our board meeting agenda this evening, and I would ask one indulgence of the board if in the motion we could move up stories that inspire hope just as our next item, just before public comment. We have an expectation of public comment for a while, and I just wanted the individuals who came for that stories that inspire hope be able to speak.
So moved.
Okay.
Support.
A motion and support for the agenda as amended. All those in favor say aye.
Aye.
All those opposed? The motion carries. So at this time, Suzanne, if we have our stories that inspire hope for Family Caregiver Month.
Good evening. My name is Siri Sakura. I'm the Director of Justice Initiatives here at Oakland Community Health Network. I'm excited to have Courtney Thomason next to me, as well as Eve Stanley. Courtney is one of our co-responder clinicians who has been with us for the last 2.5 years. Courtney is embedded in 4 police departments in Auburn Hills, Birmingham, Rochester, and Bloomfield Township. And her and Eve connected about 1.5 years ago. So with that, I will hand it off to Courtney. She will tell you a little bit about her job, but then most importantly, you get to hear from Eve.
Hello, again, my name is Courtney Thompson. I'm a co-responder here. For those who are not familiar with our co-responder program, we're clinicians embedded into our law enforcement agencies here in Oakland County to provide service coordination, support, de-escalation, any kind of way we can support individuals in the community that have police involvement. That's what we're there for, and as well as the families of those people that we serve out in the community. I was able to connect with Eve through our police department to support her in getting resources for her adult child, or her daughter, excuse me. So we'll let Eve talk a little bit about that experience of us working together.
Hi, good evening, everyone. Grateful to be here and to be able to share a little bit my gratitude. It turned out that Courtney spoke with me when I was in a real extreme crisis with my young adult child, who was really unwilling to go and get help for mental health, and she was able to direct me and help me to go and get petition the court to be able to get help. And the police department was incredibly caring and sensitive and able to talk to my child in a way that I really appreciate, and to get them to go and get services. And then I talked with Courtney later on, and she was able to help me discern where they might be able to go to stay, because they couldn't come back and stay with me. And feeling grateful for that, and appreciative that there is a service like this to help when a mother can be really in crisis with handling those kind of situations. So I just wanted to express my gratitude. She came back into my mind recently. I didn't even know that this was going on, so I was grateful that I'd called and found out. I'd called her just to thank her again. My child is doing much better, much more stable, and has a really nice group home in Bloomfield Hills now. So I just wanted to share my experience and just to appreciate the services that exist in the county. Thank you.
Well, we want to thank all of you for coming tonight, sharing your story. It's a section we always have at every board meeting about stories that inspire hope with things that we're doing in the community, and also people who are using services and families that are affected. And I'm glad you said your daughter's doing well, because I was going to ask that question. And so it sounds like things are in a better place, and you're in a better place. So any other board members have any comments? Well, we want to thank you for coming. All right, next is opportunity for public comment. We do have a number of people that have signed in, and I'm going to call their names off, and I hope I get the names right, and I apologize if I don't. We would ask that when you speak to the board, that it's to the board as a whole, and also please limit your comments to 3 minutes. So at this time, I'm going to start off. We'll hold off on the online comments till later. Just remind me. So, and if anyone comes in later, changes their mind, and they're not on the list, I will ask for a show of hands if anybody wants to speak after the individuals who have signed in. So first on the list is Roman Gasky.
Hello to the board. My name is Roman Gasky, and I'm running for state representative in the 54th district. I'm from Lake Orion, and I'm just really here just in support of transparency for our nonprofit providers. As you are probably aware, a lot of them have showed up today. They're really here just to hear from the board exactly what is the plan and what is going on. And while I'm on this topic, I want to pivot to Lansing. There's a concerning plan, in my opinion, to reduce the number of PIHPs in the state from 10 to 3. These are the organizations that control how our Medicaid dollars are spent on mental health. By taking this move, we take power, in my opinion, both away from our local nonprofit providers and from an organization like yourself, because we're basically saying instead of Oakland County determining how these dollars are spent, a greater organization is determining how those are spent. So for the sake of transparency and accountability, I just wanted to speak in support of those ideas today. Thank you.
Thank you. Next, Kevin, I believe it's Sodi with New Oakland. Yeah. That's fine. Good evening, board.
Good evening, board. Kevin Sendy, President and CEO of New Oakland Family Centers. I'm really going to defer my time to Dan Sharon from the MyCare Council, who he is a representative for a consortium of providers in the county, and I'll defer to him to speak on that regard. But I think the most important thing is we're here on behalf of the clients and families of Oakland County, and we really want what's best for them, which is, I think, what we all want, including OCHN. So.
Thank you. Good evening. As mentioned, my name is Dan Sharon, Executive Director of the MyCare Council. I also lead 2 other statewide associations of behavioral health and SUD providers, and I'm a resident here in Oakland County. Our member agencies form the backbone of the provider network here in Oakland County. When that network is destabilized without planning, consultation, or clear transition, there are real risks to continuity of care, workforce stability, and your statutory obligation to ensure a stable, adequate system. Tonight, my public comment focuses on OCHN's publicly announced decision earlier today to take over adult crisis services beginning in January. What was previously implied and what we thought were negotiations is now official. But even with today's announcement, the core concerns remain the same. This decision carries operational, financial, and human consequences. It deserves careful deliberation and clear answers before anything moves forward. Let me start with what matters most, the people. The people behind every data point, contract, and referral. I appreciate the stories that we just heard that inspire hope for our providers, especially those in crisis, and those in crisis have a lot of stories to share. A young man told one of our providers, most people talk about how they found an organization. I talk about how mine found me when I was homeless. Another told the provider, you saved my life and helped me find normalcy and the right medication. A mother told us during the darkest moment for our family, a weight was lifted off my shoulders because someone finally saw what we saw. And a parent with a child with autism said, she is thriving. She has become our family's little rock star. These are the lives held together by your provider network. These are the people who walk through our providers' crisis doors at 2 a.m. or pick up the phone when they have nowhere else to turn. Their stories are the heart of why providers do this work. And that is why providers were shocked, first by the internal signals, and now, as of this morning, by OCHN's formal public announcement that will take over crisis services. Weeks prior to this morning's announcement, OCHN had already posted 27 new crisis jobs, raising concerns among the workforce. That it has actively encouraged provider staff to leave common ground and apply to OCHN, such as this flyer. All without a collaborative process or discussion. From the outside, these actions look like a violation of OCHN's statutory duty to maintain a stable, adequate provider network, while exposing the organization to additional legal risk and raising questions about judgment and ethics. This is a major deviation from decades of practice. It was not raised publicly, and it was not discussed with partners. It is quite simply an involuntary transfer of service from long-standing providers to OCHN. I understand that this board includes people with lived experience and people who have worked inside the very organizations you now want to replace. You know how specialized crisis work is. You also know the training, supervision, and infrastructure it requires. Let me give you a sense of scale. Last year, Common Ground managed roughly 30,000 crisis contacts in Oakland County, contributing to more than 165,000 statewide. Across the county, our member provider network serves over 60,000 residents every year, including thousands of children, and employs over 1,800 people locally. These organizations bring over 400 years of combined experience in crisis care, outpatient services, community support, and other essential services throughout the county. This depth of expertise and the workforce behind it is not something OCHN can replicate or afford to lose. And with the workforce shortage already straining the system, sudden job uncertainty, combined with OCHN actively recruiting provider staff, will push people out of the network. Yet, if OCHN proceeds with this hostile takeover, the entire system will be upended, despite no performance failures, no documented deficiencies, and no continuity of operations plans. I cannot recall a time when OCHN has ever directly provided crisis services, but I can tell you about Common Ground. In fact, its most recent contract score was 94.8%. They met or exceeded every key performance indicator that this board reviewed in August. Their complaint rate was 0.02%. Nationally, they are recognized as leaders in crisis care. So naturally, people are asking, why now? Tonight, we've heard several explanations, and tonight I'll address only two, but happy to discuss the others. First, we heard OCHN is statutorily required to directly deliver services. It's not. The Michigan Administrative Code clearly states a community mental health board shall ensure mental health services are provided directly by contract or by formal agreement with public or private agencies or individuals. If direct delivery were legally required, it would have been required for the past 30 years, not announced 60 days before implementation. Second, we've heard OCHN must deliver crisis services because it's the state-sanctioned crisis provider. The Mental Health Code does require 24/7 crisis response to exist, but it does not require OCHN to be the entity performing it. Contracting fulfills this statute, and OCHN has relied on that model for decades. I encourage you to conduct your own due diligence on all the reasons why. Now let me just speak to you as someone who has served and continues to serve on nonprofit boards. Board members are fiduciaries. You are expected to exercise independent judgment, ask difficult questions, understand foreseeable risks, and hold your leadership accountable in advancing the mission of your organization. With the system already fragile, with workforce shortages worsening, and with the state actively rebidding PIHP regions, which we support, fiduciary duty requires heightened diligence, not accelerated change. If OCHN wins the new PIHP contract, it cannot be a service provider, and I've already alerted the Department of Health and Human Services and State Attorney General of OCHN's interest in remaining a service provider based on today's announcement. I'm also glad to see our state representatives, Dave Martin, Sharon McDonnell, and Josh Schreiber here this evening, if they made it. If OCHN does not win, entering the service arena raises entirely different concerns about oversight, governance, and organizational stability. Moving ahead now, before the state's decision creates avoidable and foreseeable risk. The state has been explicit. The new PIHP model is designed to remove conflicts where entities function as both payer and provider. OCHN today is both. Expanding into direct services now can easily be interpreted as self-preservation, not system improvement. And this isn't just about crisis care. Your decisions ripple outward into child welfare, foster care, early childhood services, and other safety net supports that rely on stability in this network. And frankly, your provider network is concerned to see what other services you will seize in an effort to sustain your organization in a redesigned system of care. The system is fragile. Work shortages are real. Families are overwhelmed, and provider staff are now worried about their jobs. When the network destabilizes, people in crisis pay the price. Before you proceed with taking over services providers have delivered for more than 30 years, there are basic questions any board member should ask. What evidence shows OCHN can deliver crisis services at the level providers deliver them today? How will OCHN recruit and train more than 150 crisis staff? What contingencies ensure uninterrupted service? How will this affect the PIHP rebid if you win? Does this improve care of Oakland County residents more than what is being provided today? And what risk does this create for the organization and for you in your fiduciary capacity? Providers and the people served want a partnership grounded in transparency, respect, and trust. But abrupt changes, contract cancellations, declining referrals, and actively recruiting staff away from your provider network have already introduced instability, eroded trust, and fractured the provider network you are responsible for. Providers are not asking you to reject change. They're asking you to protect the system entrusted in your care and ensure any change is thoughtful, transparent, and aligned with the people we all serve. I urge you to take this moment, ask the questions you need, and ensure that any decisions you make strengthen rather than fracture the stability of Oakland County's behavioral health system. I have my comments I'm happy to submit to you for the record, and thank you for your time.
Thank you. Lisa Kowalski.
Thank you. I am a parent of an adult with autism, and I live in Rochester Hills. And I'm here today as a parent. Does OCHN care enough for the people who you serve to take a step back and get the current undertakings in great working order? I'm exceedingly concerned that OCHN continues to pull critical services in-house without a comprehensive project management plan that includes the stakeholders and truly ensures that there are no lapses in service or care. You just announced Common Ground services were being pulled in-house with a lot of flowery reasons why, claiming improvements will occur. But my personal experience with OCHN pulling services in-house has been exceptionally poor, and your attitude for supporting frontline providers has not been good either. You want providers to train OCHN employees on how to do the job. You want them to solve the problems that you create, and then all while offering less financial compensation and not coordinating your communication. Your track record on transitioning transportation had a lot of bumps in that road, and your track record with the FMS services shows that OCHN has caused chaos in billing services and a great deal of unreasonable stress on the provider network. OCHN has been putting cost burdens on the providers, which weakens our care network. And many of these burdens were caused by not having your staff knowledgeable of what was needed in OCHN and the billing systems and how they work and how funding streams flow, and for not showing urgency when things aren't going and running well. You repeatedly ask the same for the same information over and over again. You don't communicate well. The providers who are in the front lines for our family members' care were shielded by a lot of this. Right now, OCHN needs to approve more than 100 authorizations so that people with developmental disabilities can receive support services. I wrote a letter to OCHN because now my son ended up being one of those 100 people. And I'm very knowledgeable about how all this stuff works. OCHN responded saying that we needed to submit to you over a month in advance of when his year period ended, and yet we received no communication that the timeline for doing pre-planning changed whatsoever. How is any of this being communicated to families? And what are you doing about your 100 authorization backlog? Should OCHN have more urgent response? You're treating your provider network poorly. I've witnessed the provider network and the care for people that you're serving becoming more and more vulnerable because of your actions. Please step back and get things in order before you tackle something else. Thank you.
Thank you. Next, Representative David Martin.
Good evening. Thank you for your time. I'm David Martin. I represent the 68th House District, which includes Groveland Township here in Oakland. So people have contacted me, and I've been curious about, the watchword in Lansing is transparency. So I really want to express and echo the transparency that is brought forward here. When I was a Genesee County Commissioner, I went through combining the community health, mental health with Genesee Health System, and I know how difficult the communication is to make sure that those mergers happen with everybody's knowledge and with a plan for the future and their comfort level. Speaking of comfort, I was a veteran service coordinator at Mott Community College. I had to deal a lot with different counseling agencies. My wife is a two-tour an Iraq veteran, PTSD, has a service dog, and I know that how much the agencies that they get serviced by, the comfort and trust from to the providers that they get, and the changes are very difficult when they change providers or have to go to somebody different because of the trust and comfort level that the patient, if you want to call it that, but the service members themselves, what they look forward to and open up to, and it's a huge responsibility for the provider to provide that comfort and trust. And any change in that risks either stop getting counseling or it just interrupts it, and it's kind of detrimental to their actual services. So I just encourage you to continue to open up to transparency and the communication to the providers, and of course, the providers can then communicate that to their patients. Thank you for your time.
Thank you. Ann Bradley, Common Ground.
Good evening. I am not here as an employee of Common Ground, but rather as a private citizen.
Okay.
And I have thoughts I would love
Right.
to express to you. And I find that I may be echoing what you have already heard, so I'll keep this brief. This may feel like an attack, and it is not. It's concern about this transition being in the best interests of our communities. Because this is not an ordinary acquisition, and I am not being hyperbolic when I say people will die as a result of poor service transition. This is not a normal M&A. This is crisis services. These are frontline people. We're talking about suicide prevention here. This is serious business, and it is not being treated that way, and that's a problem, not just for you as an organization or us as a provider, but for the people in our community, the people that OCHN purports to serve. OCHN has the conflict of interest. They have no experience in crisis care. All of that is true, but more than that, looking at how this transition has been handled, looking at these facts, it appears the agency is not acting in good faith as one would expect, but is acting out of fear, out of monetary deficit perhaps, and a desire to be seen as a leader rather than actually leading. I would ask this group in the strongest possible terms to hold your leaders to account and act in an accountable way. Pause this poorly planned transition. Consider if these actions are in the best interests of those you serve. You began this meeting with stories that inspire hope, and I urge you to make this transition another. Thank you.
Eric DeBruzen from Common Ground.
Thank you. I am Eric DeBruzen, Common Ground Board Chair and near lifetime resident of Oakland County. Courage is the ability to stand and act for what you believe is right, fair, and equal for all, despite opposition and personal attack. On Martin Luther King Jr. Day in 2018, I received the Courage Award from the Greater Pontiac Community Coalition. The engraved glass sculpture bearing the quotation that I just read was presented to me for my contributions to diversity. The presenter, Pastor Jones, a pillar of our community and a leader who I admire and respect. Entering my 38th year of law practice, I still work 5 to 6 days a week on average, and I also sit on 2 other boards. Yet tonight, when I could be at home resting with my wife and dogs, I summoned my courage again to come before you to ask a single question. Who on your board will have the courage to be my partner to seek the truth, to listen, and to provide board oversights of negotiations of the transition of Common Ground Services to OCHN, and to do so with haste? I need a partner from your board because, in my opinion, the efforts to negotiate the transition so far are failing, and the clock is ticking. I need a partner who is committed to seek the truth, one who will demand to see the evidence to support any allegation made, and if there is no evidence, to challenge why the allegation was made in the first place. I need a partner who will listen, who understands business negotiations, and who also appreciates the important distinction between interests of a party and positions of a party. Finally, I need a partner who understands that a fair agreement here requires reasonable compromises to address the interests of Common Ground and not just those of OCHN, so that both sides come away feeling like a winner. I am an optimist, and I believe that each one of you takes your position very seriously. I listened to the Committee of the Whole meeting last week, which validated that belief, as some of you spoke out seeking to learn more so that the OCHN takeover would not be merely given a rubber stamp approval. And yes, in many, but not all circumstances, I also agree with those who said that change happens. Common Ground is and has been preparing for a change. But given the recent conduct of OCHN, including today's surprise press release, uncertainty to those we serve, and the potential for more irreparable harm to Common Ground rises daily. That is precisely why I implore you to summon your courage, accept my offer, and join with me to get a fair transition agreement concluded now. Thank you.
Heather Ray, Common Ground.
Good evening. I'm here tonight to tell you what you should already know, which is there is no transition plan. There is no agreed upon parameters of this plan. There has been no meetings to discuss what the plan entails. It was dropped into our FY26 contract, and Common Ground was told to sign it. That has been the extent of any conversation. So I am very concerned that there is no transition plan, and that we are not aware of that seems like a big deal. This should be something that we are doing together, not in a spirit of Common Ground, you don't get to have a say. Common Ground, you don't get to be a part of the planning. We will give you the plan, and you shall implement it. That has been the spirit of this collaboration. Now that is very dangerous because that type of attitude has led to non-payment of Common Ground for the month of October, and we were told if you don't sign the contract, you're not going to get paid. So we did not get paid in October, and then in November, I had to contact Dana Lazenby because we didn't get paid again, and we were told if you don't sign the lease, we're not going to pay you. So thank you, Dana, for correcting that. But this is, extortion maybe? I don't know. I'm not an attorney. I'm not sure what to call it, but it is completely inappropriate and deplorable for OCHN to not pay providers or communicate that they weren't going to pay them. And the adversarial and threatening nature of this relationship that OCHN has with all of their providers is a reflection of you. And you shouldn't have to bear that reflection. This should be a board that you're proud of, an organization that you're proud of, that acts with integrity. And I ask you, demand that from your leadership. Thank you.
David Newhouse.
Good evening, ladies and gentlemen, members of the board. My name is Dave. I'm a 15-year Army vet with 3 tours. I've been working at Common Ground for the past 2.5 years with the Sober Support Unit as a medical technician. I sit here to ask a question that is both popular and common within the Resource and Crisis Center. Why? Why does OCHN want to absorb Common Ground, an already well-established community health center? Your representatives have stated that OCHN is absorbing Common Ground to improve services for the community. That's it, no other explanation. But the question still stands, why? What services has Common Ground fallen short of to the point where OCHN needs to step in and take over? Everyone's heard the success numbers with Common Ground. So again, why? Where's the reasoning? As a first-time provider, what services can OCHN approve? Now, looking past the apparent soon-to-be conflict of interest, OCHN's actions or lack thereof, in attempts to make this transition easy has created a very, very uneasy, tension-filled, hostile work environment. I gotta say, I wasn't even that tense when I deployed to Afghanistan. Everyone is still so unsure about their job, the jobs they are supposed to provide for them and their families during this fast approaching holiday season. The only information we receive, with the exception of today, is apply. Apply for our jobs that some of us have been working for the past 20 years. We need transparency regarding our job security. We need a plan. Everyone in that building is willing to be a team player in all this, but we need to know what sport we're playing. As a disabled veteran myself, I can genuinely tell you that I've received better communication from the VA system. I see all of you here. I don't recognize a single face. That tells me one thing, that no one has stepped foot in that building in the last 2 years, and I encourage every one of you to do so. Please, we need better clarity. We need better communication. We need a plan. Thank you.
Debbie Smith? Okay. So Debbie, does Debbie want to speak? Yeah. Okay, all right, thank you. Art Ingraham?
Good evening. My name is Art Ingram. I'm a resident of Rose Township, Oakland County. My involvement with Common Ground crosses a lot of different paths. I'm a Marine Corps Vietnam veteran, and I also am the co-founder of a Veterans Resource Center. I'm on the board and also the treasurer for the Oakland County, our community coalition. And I also am a police officer with the Holly Police Department. And so a lot of the different things that I get involved with also involves Common Ground. I started about 10 years ago working at Common Ground as a volunteer on the phone line. When the pandemic hit, I was forced to then do something else because they only could use staff members. I started doing the outreach program and went to schools and health fairs or whatever representing Common Ground. Later on, I had a position with Common Ground in the admission area, and I work in the lobby and provide crisis intervention for some of the people that come to us, maybe directly from a hospital, maybe from a jail, maybe from wherever. And the one thing that I know is that working on the phone line in the beginning, we would have people that would call frequently. And I could never say I can't talk to you or not talk to them because I never knew if this was the day that they were going to carry out what they have said they were going to do 30 times before. And that only comes from experience. It comes from working that phone line for a long time. And then I think when I do the outreach programs and I talk to all the people out there and I listen to their issues and their problems, I always recommend that they can go to Common Ground. And most of them know Common Ground by reputation. And I guess an agency that they believe in and they trust. And then I think in my job at the Holly Police Department, I do a lot of with the domestic violence, with children, with maybe people that are in crisis or maybe people that are suicidal. And I have many times transported people from Holly to Common Ground because I trust them, not only from being there and working there, I see the people firsthand. And a lot of the people that work at Common Ground, it isn't just a job for them. This is something they believe in. I could tell you stories about some of the people that I work with that will actually go out and buy lighters and buy cigarettes and bring in decorations and bring in their own clothes for other people. Okay? And so I think that Tom Brown's been doing this for 50 years. They have the trust of the local people, and I hope that we can continue providing that service. Thank you.
Thank you. Next is Josh, and I can't make the name out. It says state rep, and I apologize.
Hi, my name is Josh Shriver. I'm a state representative in northern Oakland and Macomb County. My district is number 66. Prior to being elected as a state representative, well, I guess technically I still am a board certified behavior analyst. In the field of applied behavior analysis, we work frequently with CMHs, our clients, depend on those monies in order to receive the services they require to become higher functioning, to reach their full potential. My wife and I are both engaged in this field, and I'm here to speak as a state representative, knowing how the allocation of resources impacts children in a real way, but I'm also here to speak in my capacity as a board certified behavior analyst with experience in the field, working one-on-one with families. The proposal, well, I was off script there, but I prepared some words, so.
Go right ahead.
The proposal for Oakland County Health, Oakland Community Health Network to take over all crisis services is not a small administrative adjustment. It's a major shift in how this entire county responds to people in crisis. A change of this magnitude must be handled openly, with full transparency, and with the clear involvement of this board and the public. Community providers, like some that have already spoken today, have built decades of experience in crisis work. They have trained staff, they have 24/7 readiness, and they have trusted relationships with law enforcement, hospitals, and families. They are the boots on the ground responders who know how to manage a crisis in real time. Removing them without a clear transition plan risks serious disruption in care. As someone who has worked with families in moments of real need, I can tell you that stability and continuity matter. When a child is in crisis, or when a parent is desperate for immediate help, any break in the system can mean the difference between safety and tragedy. There's no confusion, no room for rushed handoffs, and certainly no room for administrative experiments. There are also serious governance concerns. When the same organization manages funding, sets the rules, and delivers services, that creates a built-in conflict of interest. Crisis care requires independent oversight so that quality, accountability, and public trust remain intact. Oversight cannot be done by the same entity that is grading its own performance. Just as importantly, this decision has moved forward without a formal board vote, without public hearings, and without the transparency that our community expects and deserves. Oakland County deserves an open process. Families deserve to know how their crisis system will change. Staff deserve clarity about their jobs and training. My community deserves answers. For all of these reasons, I strongly urge this board to pause, hold a full public hearing, and bring this matter to a formal vote. This is about protecting the safety and stability of the people we serve. This is about maintaining a crisis system that works. And this is about making sure that major public decisions are made in the light with everyone at the table. Thank you for your time and for your commitment to the people of Oakland County. God bless you.
Thank you. That is the list of individuals who signed up. Is there anyone else who's entered sunset time or would like to speak? Yeah.
Good evening, everybody. I've been with Common Ground 30 years, and
Could you please state your name?
Oh,
please?
Mary Bonds.
Thank you.
I've had a lot of different roles, clinician roles at Common Ground over the years. I worked the crisis hotline. I think we have over 250 frequent callers that have a profile of how the crisis worker can deal with the callers. I think if OCHN takes over, I think our frequent callers and other callers are going to feel helpless, hopeless, devastated. They don't know who they're talking to. We know them by their name, and I think that it's a disservice. I think Common Ground saves lives every day, every minute, every second of the day. We help people go from crisis to hope. Common Ground never gives up. So my concern is, if this happens, I think there's going to be a significant increase in substance abuse overdose, mental health crises. I've had recent domestic violence calls for 2 hours. I think there's going to be an increase in women of domestic violence being killed and murdered by their husband, boyfriend, whatever. And it's very unfortunate and very sad because Common Ground does everything. I mean, Common Ground's the best. It doesn't get better than Common Ground. And I'm glad that I was able to speak, but it's really unfortunate. And my concern is if you do take over, when they call, they're going to say, who am I speaking to? What's your name? Oh, where are you from? These callers know us like to the extreme. Trust, and for them to develop trust and honesty and to trust people is a big deal. I mean, I had several calls today. A woman, they can't get out of bed. They're depressed. They don't want to get out of bed. They're depressed. They don't eat. Then they sleep all day. These are individuals that need immense crisis intervention services, and I completed a 96-hour crisis intervention training at Common Ground twice. I have a bachelor's in social work and a master's, and you don't get that in college. If you go to a college or university, no, that's it. Common Ground was the best training I've ever received, and that's why I've been with them 30 years. So I think this would be a huge mistake, and I can't tell you how many other students that I've met, undergrad and grad, and they said, Common Ground is the first and only place I've gotten training, and that's what Common Ground is about. So I think you need to really look closely and think about, how it's going to affect our community, our services, and our callers. The frequent callers I'm very concerned about, very concerned about. They all have a profile, and I think they're going to feel neglected and abandoned if you take over. I strongly feel that way, in my opinion and my thoughts, so it's not a good thing.
Thank you. Is there anyone else who wishes to address? Yes.
Thank you very much. I'm State Senator Rosemary Bayer, representing Senate District 13 and all of Oakland County. In my work, I have focused on helping the entire county in many ways, including providing support for new opportunities to improve our healthcare system, especially in mental health. I have been a partner to OCHN for years, as well as many service providers throughout the county. The mental health system we have here in Oakland County is not perfect, but it is really good. We are known here to have the best system in the state, widely, certainly in Lansing. I recognize that the significant changes that the State Department dropped on you recently with inadequate research and inadequate stakeholder involvement, and it's causing stress here at OCHN and putting our county public health system at risk. The State Department is not a good role model for us. What they did is not a good idea for us. Do not emulate their method of improving critical systems by enacting sudden, dramatic, big, risky changes without collaborating with the major parts of the system. I came today to ask you to take a different path, to work collaboratively with your service providers, your partners, instead of embarking on a path which will be difficult, expensive, stressful, exhausting, and unlikely to improve, or perhaps even be harmful. The disruption of rebuilding will make it very difficult to meet the needs of the community for some time. I came today to ask you to take a path that puts the people that we serve first. To think hard about the risk you would take causing damage to our mental health care system, damage to the mental health of the people of Oakland County. Many of the people serviced by Common Ground, Easter Seals MORC, CNS, many more agencies, the people they serve live on the edge. They don't actually have a backup. They don't have another alternative. The time that it takes to change over a system like this and to make it work effectively again, not going to be quick. It's going to hurt a lot of people. They don't have a backup plan. I really urge you to take a different path, to build more strengths in this public health system, more strengths in our capability to help our people. Your provider partners are strong. They provide nationally recognized skill levels and quality of care, thousands of employees and tens of thousands of people that they take care of with you. So please, let's just sit down together, build collaborative solutions, improve services, make our system stronger and our people healthier. Thank you.
Anyone else? Yes.
Good evening. I am State Representative Sharon McDonald. I represent HD 56, 5 communities in Oakland County, including Troy. So welcome to everybody here to my district. You've created a miracle. You have put me and Rep. Shriver on the same side, which doesn't happen often.
Bringing people together.
Yes, indeed. Hasn't happened since DTE, so rate your popularity. I am also the chair of the Michigan Legislative Disability Caucus. In that capacity, I've learned a lot about PIHP payers. I also hear often from OCHN, its clients and providers. Earlier this year, when MDHHS announced its plans to reform Michigan's PIHP payer system, I paid very close attention. In a legislative briefing, MDHHS Executive Director Hertel made the reform goals very clear. She wanted to simplify the PIHP system by reducing the number of PIHPs from 10 to 3, and she wanted to eliminate conflicts of interest, especially ending the practice of PIHPs competing with or absorbing their own providers. And I absolutely support these reforms. In fairness, OCHN is not the only PIHP in Michigan that competes with its own providers, but it is a practice that can put providers out of business, hurt clients, and increase costs while limiting services. But the key is, I think we know about recent lawsuits, and they're going to win. Michigan PIHP reform will begin on October 1, 2026. If OCHN becomes one of the 3 remaining PIHPs in Michigan, it cannot be both payer and provider. If OCHN becomes just a CMHSP, there's no need to absorb a provider that's already doing a great job. So why is OCHN trying to take over Common Ground? I guess it's already happened today. I didn't know that coming in. It's amazing. All, even though their needs are not at all identical. There were reasons that there were different costs for transportation. Somebody could be jumping into an Uber, or somebody could require a large vehicle that's worth $80,000 and at least one aide or two. But we treat it like widgets. Are we treating clients like widgets? Their needs are very individual. Providers, clients, and families begged OCHN not to do this, or at least to take input for over a year. So they reported back to me that OCHN plowed through, signing a contract. The one I know about best is Motive Care. I think it may be the only one in Oakland County. But then at a February 2025 meeting, just 3 months later, I attended this meeting, and clients and families were furious and devastated because Motive Care refused to allow aides to ride with clients. This is the transition, an obvious safety issue for so many people with disabilities and IDDs. Families told me they had tried to stop OCHN from making poor decisions. They had tried to make OCHN listen to, if they were going to do a transition, what they needed to do, what they needed to not forget, who they needed to remember before just throwing a system away. Families told me that they'd tried, but they weren't listened to. Unbelievably soon after that meeting, OCHN came to my office asking for my help to fix the unbreakable contract they had signed with Motive Care that endangered their own clients. Why was I put in that position? Why was that big mistake made? I don't know, but I was asked to help fix it. Now, with a major statewide reform months away, this is not the time to wreak havoc on our mental health system in Oakland County. Please pause from taking over Common Ground. You need a transition, not a hostile takeover. It just doesn't make sense, and it's bad for Oakland County's most vulnerable people. Please let the experts do the care. We know who they are. Where is the oversight? Where is the transparency? Why do I keep being told by everybody there's nothing we can do? Who can do it? Who can fix this bad decision? Isn't that you guys? Could you please do that, please? Thank you.
Is there anyone else who wishes to address the, yes?
So Sheila Barrett as a resident of Oakland County, not OCHN employee.
Okay.
So I have two experiences with family members going to Common Ground. One is not here today, so when I sit here and say and hear lives are lost, how the experience isn't here, it's heartbreaking. My two adopted children that I had no longer have a mother because she didn't get the proper services from Common Ground when in crisis. So when I sit here and think, years and years of her trying to get proper services and going to Common Ground and getting turned away, and I hear statistics like they're so perfect. I disagree. Then, 4 months ago, my sister said I could share this story. She hit rock bottom. She went into crisis. I could have easily went around and used my connection. At this point, I'm 8 years into my employment. We went to Common Ground. I didn't use my connections. We walked in the front door at Common Ground. We went back for the intake. She was told to call the 800 number on the back of her insurance card. There was nothing they can do. So again, at that point, she was in crisis. I did not want to lose another family member. And I reached out to our access department, who immediately got her into the services she's needed. So when we talk about where this stands, it's not all perfect.
Anybody? Thank you. Is there anyone else who wishes to address the board in the audience? Is there anyone online?
If you are online and wish to speak for public comment, please raise your hand at this time. Mr. Garrett, you can go ahead and unmute your mic.
Thank you. Hello and good evening. My name is Michael Garrett, President and CEO of CNS Healthcare. We've been a core provider in this county for over 25 years, and when I heard that there were possible changes occurring with crisis services, I felt a bit compelled to speak. As a certified community behavioral health clinic, we have a vested interest in the stability and availability of crisis services in Oakland County. And for many years, Common Ground and New Oakland have been on the front line of providing these necessary and critical services to the people we serve. CNS Healthcare simply wants to ensure that changes to these mission critical services won't put the people that we serve in harm's way. Now, we all know that healthcare in this state and the country is evolving, and change is often a necessary part of that evolution. However, given the vital role that crisis services plays in the social safety net, I would simply ask that OCHN ensure and allow full transparency of any pending crisis plans, and also ensure that whatever crisis changes are made are in the best interest of the people that we serve. Because for decades, and I think I heard somebody else say this, Oakland County has had the statewide reputation of being the gold standard for high quality and effective service delivery. I simply want to ensure that we continue to live up to that lofty status. Thank you for your time this evening, and take care.
Thank you. Okay, all right. Thank you. This concludes our first opportunity for public comment. I just have a couple comments. First of all, Dana is going to give an update on the transition later on in the meeting. She also gave an update at our public meeting last Monday. Mr. DeBruzen, you did write me a letter that I received late today, and you came to the meeting. I will reach out to you by the end of the week. We have some board policies and board governance bylaws that do not allow us to get involved in negotiations of contracts, but I also believe that dialogue is always good, and I will get back to you and we will meet. Yeah. Okay. But in return, I would ask, as I have asked our executive team, for your executive team to meet as soon as possible. Because at the end of the day, board members aren't going to resolve this. It's going to be resolved by the people who are doing the work. So I would ask that. I understand that, and if that's the way you operate, that's fine. But I think it's imperative that operationally, the executive teams meet as soon as possible. Okay? Well, I don't understand. I have a simple request: is that your executive came tonight, and why can't we have a phone call and have a meeting? Yeah. Well, I said I'm willing to meet with you. I'm not going to say I'm a partner necessarily the way you see it, but I said I will get back to you by the end of the week. Okay. Okay. Thank you. And then the other thing is, this is a board that takes its job very seriously. With our partners, we serve 30,000 individuals in Oakland County and their families. Many of us have family members who receive those services, children, brothers, sisters, parents. We also have clinicians who provide service, and we have stewardship over about $530 million of public money. Believe me, we take that job very seriously. We are transparent. The taking over the responsibility for crisis care was considered by us at public meetings. It was placed in both our annual plan and 3-year plan. And we also, I believe, had a community forum about our plans. So any suggestions that we have not been transparent, I'm sorry, are misplaced. We'll continue to be transparent and provide at our board meetings updates, as Dana will do today. I agree that we do need to collaborate, and I hope that will happen. But we do have to move forward, and we hope to do that together. So that being said, we'll move on. I'll dispense with my report, and we'll move on to our September 2025 financial report. Mr. Carpenter?
Good evening. Next, we do have our September financial report and update. Just a quick caveat at the beginning. Again, September is the last month of our fiscal year 2025, and this finance report at this point in time does not take into consideration all of the audit close processes that we normally do have in place. So again, this is a preliminary September. It will change between now and the end of February when we submit our final reports to the state of Michigan, but happy to be able to provide this update to the board at this time. Next slide, please. As we look at our revenue trend, we'll see that the trend in blue is our 2024 or our prior year revenue, and the bar charts are our current year or 2025 revenue. And in a general sense, the revenue is now starting to exceed prior year on a month-over-month basis. You do see a little bit of a spike in September of 2024, and we don't expect to see the same spike in 2025. That is in part because the department did do a retro rate adjustment. And when they did that, they did a what's called a recoup and a repay, which means they went back to October of 2024, and then they pulled money back, and then they pushed money out for every month based on the new rates that were identified by the state. So that is why those bars may have gone up since prior months. So again, each month is the month of service that we're paid for, not the date that the payment is made. Next slide, please. When we look at eligibles, again, we have the trend of 2020 in blue, so that's pre-pandemic, just to give us a sense of where we're at in our eligibles compared to pre-pandemic, and then we have in red 2024, so we can also see comparables to prior year. And so we are seeing that we are continue to be below prior year in eligibles, and then we are right at or close to the pre-pandemic level for eligibles. One highlight for the comparative charts for our assets, our cash balance at the end of 2025 is higher than a year prior, in part due to some of our receivables being down, which you can see next to that. So that's some receivables that would have been from the state of Michigan that we would have been paid. And then also the transition from a service model to a fee-for-service payment model does have a positive impact on our cash flow at the end of the year. I would just remind the board that we do get a large payment at the end of every month, so we do get that payment and then we spend that down and then we get in a payment at the end of the following month. Next slide, please. When comparing our liabilities, we do see that vendor payables are also up compared to 1 year prior, and that would make sense in terms of the transition to the fee-for-service payment model that occurred in July. Next slide, please. So in total, if we look at total assets, total liabilities, total assets are up year over year. Total liabilities are also up year over year, with our net position at this point projected to be down about $2.2 million in 2025 compared to 2024. Next slide, please. On the revenue comparison, our revenue on the Medicaid side is up about $30 million, again, in part to do with the change in the rates received from the state, and part of those being retroactive. So again, revenue that we didn't necessarily know we were going to get until the last couple of months in the fiscal year. Next slide, please. In comparison, our provider network expenses are up slightly, a couple million. And so instead, again, and we'll talk about this in a little bit, but instead of then a change in net assets of about a negative $24 million this year, we're projecting a negative change of about $2 million. So we do anticipate continuing to use more expenses than revenue available in 2025. Next slide, please. Which you can see on this slide where we have total revenue comparison where revenue is up, total expense comparison where expenses are also up. And so the change in the net income or change in fund balance is still negative, but significantly improved, a $2 million projected negative compared to our 24 audited negative from 2024. The next couple slides talk about our top 12 providers by volume of payment. So we have the graph, and then we also have a description on the next slide of the services. And then we have our monthly finance report that takes the same information in the graphs, but talks about them in more detail. We did have a couple of questions that were posed at the COW last week that I wanted to address. We did have a question related to the fringes in the general administration section, looking like it was up compared to prior year, about 1.7 million. And at this point, we did make some changes in our general ledger software chart of accounts. The intent of those changes that were effective on October 1st, but we did apply them to September as we were doing September close, includes separating out mental health and SUD into two separate funds. The impact of that short term is that the benefits that we have to allocate between the two funds are sitting, and including grants, are sitting in this line item. So this does include, as was asked, some grant-related fringe benefit costs. And so we will separate that out in future monthly financial statements. The other questions that were asked had to do with community inpatient, which appeared to be down in 2025 compared to 2024, and that in part had to do with a hospital rate adjuster payment that we get direction from the state when to pay that and how much to pay. That direction for the fourth quarter did not come until last Thursday, so that information was not available to include in the financial statements when they were prepared. And that was almost $6 million, $5.5 to $6 million, just that one payment. And so that will be included in the updated financial statements. And then
for year end September 30?
It will be accrued back to September 30, yes. The good news is that the hospital rate adjuster payment is both a revenue and an expense, so the state does pay us for both of those. So it will have a zero bottom line impact, but it does impact this particular expense line item, and so that's why it looked a little different than we would have anticipated.
Right.
And then the last question that was asked had to do with the mental health and IDD service line, which appeared to be up compared to prior year of about $8 million, and that does appear to be correct, that it is higher in 2025 than 2024. That in part could be related to utilization. At this point in time, we don't expect that our utilization trends for 2025 are complete, meaning there are still some claims that might be outstanding for 2025 that we have not received or paid yet, though that due date has been extended into November. So we should be able to do a utilization review for that, but we are spending more in that line item, or projected to spend more in that line item for 2025 than we did in 2024. Those are my highlights for the September finance report. Again, as I mentioned, we did make a general ledger chart of accounts change in October. As we review the data in there, that has had impacts on, of course, the financials. It has had impact on payments to providers, which we acknowledge, and so we're trying to make sure that that's addressed and that those payments are continue to be timely and going out the door. So, thank you. Questions?
Sarah?
Just have a question. When do our payments go out? So for, let's say, October, when are those paid?
So we have right now, under the fee-for-service model, payments go out based on when the claim is received. So if we're talking about a fee-for-service payment, once that's received, we typically have 30 days to pay clean claims. And then we do have a payment calendar that we're providing so that if a claim is received by a date, then we intend to pay by a date, and we try to have that calendar updated. So.
And then all providers are being paid for submissions that were placed?
We believe that we're caught up at this point in time, yes.
Okay. Including Common Ground? Is
Common,
or will be paid?
Common Ground is not on a fee-for-service model right now, so they're not fee-for-service. They are on a prepayment, and the expectation is that they will be paid, yes.
Thank you.
Yes.
We had a public comment about authorizations not being cleared, like 1,000, I think it was mentioned. I don't want to put you on the spot, but do you know what that's referring to and what's going on?
I don't work in the authorization area, which would be related to our utilization management department. So unfortunately, I cannot speak to that specifically.
Yeah, go ahead, Chris.
I can speak to that. We are looking at our authorizations, and what we have is almost an automatic approval. If a case or a situation fits certain guidelines, there's an automatic approval. If a case does not, and it's maybe a request for additional services that are beyond those guidelines, we have clinical specialists that review those cases and make authorization decisions. We do know that some of our cases have, particularly with FMS, the fiscal management services, have been taking a little longer to review, but we are working diligently to make sure that those cases are reviewed in a timely manner. And I think there was a comment related to having cases reviewed a month before or submission a month before. That is also at the provider level in terms of the supports coordinators and case managers that are working with families and individuals served to make sure that they are reviewing authorizations and reviewing really their plan of service to make sure it's up to date and they're submitting those things in a timely manner. So it's really a collaboration and working together to make sure those things are submitted timely, but also making sure that on our side that they're being reviewed in a timely fashion. And if they're not, there may be some things that are pushed back to the provider to provide more information. Maybe there's a question or some reason why they may be delayed. So I heard 100 cases. I didn't quite hear 1,000, I hope. But we can get an update for you on that as well.
Any other questions for Richard? Yes.
So I was reading deep in the minutes of, I think it was CAC or something about, or no, of the SUD committee, about Public Act 2 funding being non-existent or what. Can you just educate me a little bit on what's going on there?
I'll do my best. So Public Act 2, sometimes referred to as liquor tax, or also sometimes referred to as the Convention Facility Fund tax that is assessed by the state of Michigan, is used in part to fund local services for substance use disorder. So it could be, we use it as a grant match. It could be that we're using it for certain services that maybe Medicaid won't pay for, right? So that's kind of the purpose of the PA2. We did not receive a July payment for PA2. And that was a surprise, not just to OCHN, but that was a surprise to all the PIHPs. We typically get payments. The January payment typically doesn't come in, or it's very low, and then we have a payment in April, July, and October. So we were expecting a July payment. We didn't get one, and we got notification from the Michigan Department of Treasury that funding was used to pay debt service for the convention facility bonds that had been issued. So there are new convention facility bonds. We did get a payment in October, and that payment in October was a little bit larger than is normal. So we do think that some of that funding has now been received, and I don't think we knew that exactly at the time that the SUD Oversight Policy Board had met. But that was our concern, is that we were missing a payment, and it's not because we lost it, it's because it never came through from the state to the county, and therefore there was nothing for the county to remit to us. So that's part of that was reported to the Oversight Policy Board. Yep.
Mr.
Yes.
Chairman,
Pastor Jones.
in relation to this, and I know we've heard this delay. Do we have a process in place for notification, timely notification and follow-up? So as in relation to what you just said, you missed that a payment was due that did not come to you, which then would have delayed the payment to whomever. Is there a process in place that you would be able to say to the person who is expecting their payment, there is a delay, we're following up, and we will keep you posted? Or is that up to the person to keep tracking back to say, where's the payment? And I guess what I'm attempting to alleviate is anxiety, frustration, okay, because it trickles down. And so I don't know if there is a process that we have that this was delayed because of that. And you know, I've raised this statement before, that follow-up, 24-hour, 48-hour follow-up. And so I'm just, do we have something in place, you know, for that? Today, we heard a person talk about delay. And that seems to be once is the problem, next is a process, okay? And so how do we smooth that out?
Yeah, so I'm going to try to address that in two parts. Number one, I just want to make sure we're clear that the delay from the PA2 funding is unrelated to our payment delay from us downstream. So even though we were waiting on PA2 funding from the state, that did not have a negative impact that I'm aware of to the funding for SUD providers, particularly in our prevention and in some of our SUD grant space. So I would like to just say that I think those two things are unrelated, that we did continue to fund those services even while we were trying to figure out what was going on with our PA2 funding. So, and we do have a PA2 balance that we have available to use for that in our fund balance. So there was not a delay specifically related to PA2. To the question at hand is, do we have a process to identify and or communicate if there's going to be a delay in payment? The short answer is we're working to improve that process right now to alleviate or reduce any potential. I cannot promise that it will never happen, but we do want to be able to communicate to providers if there's going to be a delay for any reason, whether it's a banking issue or it is a processing issue. Our intent is to improve communication to alleviate that anxiety as much as possible.
Okay, one of the things I'd like to ask, and I don't know if as we know that's an issue. We know it's an issue. And the thing is, okay, somehow we have to report back and say, okay, here's the issue, here's what we're working on, and here's the timeline to fix it, okay? One of the worst things in the world is a person waiting for something that doesn't come or it's delayed. And what makes it even worse if you don't know it's delayed or why, okay? And I'll go back to my 24-48 hour, okay? 24-48 hour. That's very, very important to get back to whoever may be impacted. And so whether it's this issue or whether it's an issue that we know that we're having a problem with, then to say, hey, this is what's happening, and this is what we're trying to do. And I think that would relieve some of the anxiety of those persons who are offering services to us that we're trying to reimburse or what have you. So, thank you.
Thank you. Anyone else? Just a couple of points. First, I think we discussed last month that we were off about 2.2 million expenses over revenue, but it sounds like, and I know we're waiting for some true ups and things of that nature, but it's encouraging to hear that be some additional money booked into last year. I also asked you, and I thank you for having that money or the figures available, that in the past, that's 2.2, and of course it's still not final, but that's against, in the last 3 years, we expended additional 25 million last year over our revenues, 10 million the year before, and 10 million the year before that, I believe, roughly. So we're somewhere in the neighborhood of $50 million that we took out of our reserves to backstop the mental health system here in Oakland County. We didn't have to do that, but we did it willingly. We did it primarily to support many of our providers who had a lot of stress coming out of COVID and the post-COVID era. It's good to see that things have started to stabilize, and I think things that Dana has done on her team in the finance area, along with you and others and our finance team, are starting to bear some fruit, and hopefully, at least temporarily, until we don't know our future, and we don't know what's going to happen with Medicaid and some of the other programs totally. So, but for as of today, there seems to be more of a stabilization in our revenues and expenses. Also, I want to point out, I didn't have a chance to do it, but my math, to the degree that it's good, I think we're somewhere between 6.5% and 7% on administrative costs on about $537 million budget. So I think that's something we should all be proud of, that we're holding the line on costs and making sure as much money as possible gets into the system. So that's all. That's my comments. If that's all, we thank you for coming, Richard, and waiting, and we look forward to hearing from you next month.
Thank you.
All right, next is our consent agenda for board minutes, recipient rights advisory committee minutes, Committee of the Whole, Citizens Advisory, and the SUD Oversight Policy Board. These are all dealt with at once. Do I have a motion?
Move for approval.
A motion and support? Support. All those in favor say aye. Aye. All those opposed, the motion carries. Next, this is not the, this is the crisis transition update, which is a receive and file from the report that Dana gave last week, and Dana and her team, crisis team, gave last week at the meeting. And so there's no vote required on that. Is there any other business before the board this evening? Being none. Board reports. Recipient Rights Advisory Committee, Dr. Guadalupe.
Yeah, I actually gave the report at the last meeting. So we had our recipients' rights meeting on November 6th. So those meeting minutes won't be approved until our meeting on the 4th. So I gave it last month accidentally.
Okay. Christina was unable to be here, so we'll get her report at the next meeting. And then SUD Oversight Policy Board, Ms. Woodruff.
Okay. The Oversight Policy Board met on October 22nd. There was no public comment. As a board member, I provided updates to the group on what the COW meetings had gone over in the past 3 months, since we meet once a quarter. We discussed financials for June. We discussed that CCBHC will no longer pass through the county. They will be directly paid by the state. Another primary focus was the review of the CEO's annual performance and the fee-for-service payment model startup. We also discussed the number of contracts that were over $100,000 that were reviewed during the last 2 months. Most were extensions. And we talked about the crisis service being a direct run program in September. We talked about the block grant P2A funding. We were seeking an increase from flat funding from 3 to 5%. We talked about credentialing, the NCA, legal services, anti-stigma contracts, the annual plan, the strategic plan that covers 2026 through 2029, with some of the emphasis being workforce strengthening services, oversight and outreach, and the 3-year strategic plan for substance use disorder services, 24 through 26. That was what I reported on at the meeting. Ms. Suzanne Warner did the community outreach updates and the Walk a Mile, the recovery celebration, the NAMI Walk, and the fact that our own Sherry Rushman was recognized by the Cookie Grant Award. Ms. Frances Carley provided the legislative updates as it related to the RFP, the judge's ruling on October 9th. Also talked about the 2 grants that were submitted by the department on 10/13/25. One of the grants we partnered with Macomb County on, and the other was a single bid for OCHN. We talked about the proposed new regions going down from 10 to 3. The metro region, which would be composed of Wayne, Oakland, and Macomb. Central would encompass 44 different counties and all of Northern County. We also talked about the fact that we will hear about the award in February of 2026, the effects of the federal shutdown on the food assistance program, and how our CEO had been outreaching with state reps about the RFP process and advocacy priorities under the 26 through 28 strategic plan. The needs assessment, the advocacy, partnerships, and outreach. Ms. Megan Phillips provided a report on the strategic plan for SUD services. They talked about the overdose education on naltrexone, how that distribute has helped decrease overdoses by 36.7%. Talked about the strengthening of tobacco prevention and that they're We have purchased 2 hidden in plain sight kits in the vape education escape room that has been purchased. Developed how the goals for media have been met through messaging, recovery messages, billboards, cable, mail, print, radio, and other advertisements. Hillary Ball provided an update on all 12 prevention providers scored 100% on their audits, and that was kudos to them. Sherry Cook provided treatment updates. Elizabeth Taylor provided updates on the administrative audit, which had an overall score of 97%, which was consistent with the previous year. Talked about re-credentialing now being every 3 years, and currently there's 97 substance use disorders practitioners that have been credentialed through MedV. Financial update on the budget, lower eligibility through Healthy Michigan, how the rate adjustments in July and August have helped. The P2A surplus will be used to offset deficits in the general fund of Block Grant and Medicaid. And Ms. Trish Zamboa reminded the board of the need to update and complete their assigned trainings. Ms. Kelly Flynn, the board chair, discussed the open position on the board. And under new business, the minutes from July were approved, and the oversight board shared comments, and no public comments were made during that meeting. And we adjourned at 2:33. Thank you.
Thank you very much. That takes us to our second opportunity for public comment. Again, as I stated earlier, please state your name and address the board as a whole, and please limit your comments to 3 minutes. Do we have anybody else who wants to speak? Okay. All right, Sharon McDonald. Fred Fetchheimer, I think I got that right. Yes.
And I've been a resident of Oakland County for more than 50 years, and I am a former director of Common Ground. I just want to say from my point of view, the timing of the proposal to take over core providers makes absolutely no sense. Obviously, you had discussion of the RFP. There's a lawsuit pending. The department has proposed that if you're selected as a PIHP, that it's a complete conflict of interest. And if that goes through, and I understand it may not, but you're talking about transitioning a program now, or many programs, having to transition them once again within 6 to 9 months. That is certainly a recipe for disaster and not something that will serve the people of Oakland County. I also think if you're selected as PIHP, there's going to be incredible pressure on all the staff to organize for 3 counties, and I think there simply is not enough staff time and talent to both be taking over programs and to also be administering other very complex programs. So I would urge that, and I recognize lawsuit may bring a complete halt to the PIHP, recognize that the lawsuit could result in there is no conflict of interest, but I submit that until those questions are resolved in the next 6 to 9 months, it makes no sense to proceed with the takeover. So thank you.
Thank you. And I believe Janet Sarkos.
Good evening. I'm Janet Sarkos, Chief of Crisis Operations at Common Ground. Last week, I made a public comment that some of you may have heard at the Oakland County Board of Commissioners meeting. In that comment, I talked about the 19 yearly audits we participate in as one part of OCHN's administrative oversight process. I cited the overall success rates that some people have mentioned tonight, 95% compliance in 2024, and are still pending results for 25 that are again trending over 90%, but not yet complete. We are incredibly proud of the high-quality audit results that OCHN has consistently found across our services. Even so, we occasionally have complaints, and we occasionally make mistakes. Last year, the complaint rate for all of Common Ground service was 0.02%. Even though that number is very small, we take each issue incredibly seriously. Today, I'd like to talk about the process of managing problems so that you understand the efforts that go into every single issue that arises. It's important that you understand this because OCHN and their supporters have recently and will likely continue to call out and amplify past mistakes made by Common Ground. When complaints or mistakes happen, we've been called out in real time. OCHN performs either an informal or a formal investigation, depending on the circumstances. When complaints or mistakes are substantiated, OCHN has required corrective actions that may include additional training, policy and procedure changes, additional reporting and scrutiny, and in some cases, we've chosen termination of employees who did not practice our collective high standards. We've been required to cooperate, and we have always done so. These situations are never fun, but I firmly believe it is important that we are under this microscope to ensure the highest quality care is always at the forefront of our minds. We are not proud when mistakes are made, but we do own them. I learned long ago that when you're in the business of crisis, helping people with serious mental illness and substance use challenges, not everything will always go right. But even so, we continue to press on and do our best every day because it is the job we have chosen, and as the statistics show us, we do it very well. Not perfectly, but very well. This is why OCHN has contracted with us for over 3 decades. I'll wrap up with some questions. When OCHN becomes the organization that delivers services and simultaneously watches over themselves, how do you think mistakes will be handled then? Will a bright light be shined upon those mistakes? Will they be held accountable? There will no longer be an unbiased watchdog. Please think about that, and thank you for listening.
Thank you. Is there anyone else in the audience who wishes to address the board? Yes.
Hi, I'm Sydney. I'm a proud employee of OCHN, and I'm also a frontline crisis worker. I've had countless poor encounters of taking individuals to Common Ground in crisis. Today, I hear a lot of concern about the fear of lives being lost and the desire for transparency. I also hear a lot of questions for OCHN, but I have a few questions for Common Ground. What about the lives lost from those you've turned away? What about the individuals that were immediately released that were noticeably in crisis? What about your lack of collaboration and transparency with clinicians who are providing services through OCHN? Common Ground needs oversight from an organization that displays leadership, care, collaboration, and accountability like OCHN. Thank you.
Is there anyone else who wishes to address the board? Yes, right, yeah. Then I'll have you next. Okay. No, next.
Okay.
No, I'm sorry. Courtney,
I don't
right?
have it. Yes.
Yeah, all right, thank you.
Yes. Hi, me again. Sorry. I'm also well, as you know, I'm a co-responder clinician here at OCHN, and I have 2 years of experience of explaining Common Ground to individuals in the community, bringing them to Common Ground, and it's very interesting to hear other comments about the reflection the community has on Common Ground, because quite honestly, we see a significant difference working with individuals directly in the community. I can agree with the fact that we are much further along than other counties in our area in terms of what crisis services we have to offer. But as my colleague mentioned in her comments, there's been numerous times with us at the police departments where we've taken somebody to Common Ground, laid them in our trust, and we meet with them an hour later, still in crisis. There's times where we show up with our law enforcement partners and we meet them at the door with somebody in crisis, and we're met with a sense of just complete, utter, I'm trying to think of an appropriate word. They just deny the individual in crisis, and anytime we try to give our clinical or the officers try to explain the situation, it always seems like a fight rather than an open door that we like to see at OCHN. I've gotten many complaints from individuals in the community that we run on that refuse to try Common Ground again or go back there again, whether it's mental health or substance use. And as somebody that believes in the ability of that crisis service, we still continue to encourage individuals to use those resources. But it's very disappointing as a clinician that encourages that to hear constant letdowns or see the ramifications of individuals that go to Common Ground to receive a service and do not get it, because we see it, because we are out there again with the law enforcement to handle that crisis again and assist with the resource elsewhere. So I appreciate the comments of, mistakes happen, things like that. Mistakes happen, corrections need to be made, but when you see the same issue, at least from what we've seen at the police department in my co-responder role, continue 2.5 years now going on, it's very discouraging.
Thank you. Yeah, I think you. Yeah.
Okay, that sounds better. Good evening. My name is Tracy Smith. I'm the CEO for Macomb County Community Mental Health. Thank you for the opportunity to briefly speak with you. I'm here to solely offer support. As your neighboring county, we all know mental health and crisis services don't necessarily end at DeQuinder. So I'm also here to support. We have many of the same providers. They're amazing providers doing amazing things in our community. But I want to provide our unique perspective. In Macomb, one of the privileges is we've actually been providing direct services for over the last 60 years. So when the CMHs originally started, we have been providing those services consistently, but not as the solution, as a solution, in addition to the many, many amazing providers that are in our community. We have over 200 of them, with many of them being the same providers that you guys use. So I can't stress enough how dependent in the most positive way we are on our providers, but we also have a solution that allows us to be a center for our community. The example I would give you, and currently in Macomb County, if you dial 988, or we do have also our own 24/7 crisis line, it is answered by the same group of people. So if you're driving through Macomb County, even if you're driving through on vacation from Kentucky, you are going to get our staff. You're going to get Macomb County staff who live and work in that community. The benefit of doing it, it's designed more like 911, right? Like 911, when you call 911, they go, I'm going to get you to the right fire department, the right police department, the right emergency services. In Macomb, that's what you get. So if you dial that number, whether it be our 586 number or the 988, you do have the ability to immediately get to our mobile crisis team, because it's the same phone number. You get to our SUD engagement center, because it's, again, the same people answering the phone. And you also get to our urgent care and our crisis stabilization 24 hours a day. So I guess I'm just sharing our perspective for your, to share additional information and just offer support as you guys move forward on this or any future initiatives.
Thank Is there anyone else who wishes to address the board? Yes.
I'm Mary Bonds from Common Ground. And when I heard tonight that OCHN never reimbursed Common Ground for multiple months, that's despicable, it's unprofessional, and how and why can an organization like you not pay people when they deserve to get paid? It's just inappropriate. I don't get it. I don't understand. You guys are professional. Think twice before you make other decisions. And I'm very disappointed with OCHN, as well as all my colleagues and staff. So, that's it.
Is there anyone else who wishes to address the board? Is there anyone online?
If you are online and wish to speak for public comment, please raise your hand at this time.
Okay. We'll close the second opportunity for public comment. I want to thank all those who came out this evening and spoke with passion and with concern. And we appreciate you coming and you giving us food for thought. But at this time, I'll turn it over to Dana Lazenby for her director's report, including an update on where we are at with the crisis services transition.
Good evening, and thank you all for your public comment. As you can see, there's some very different sides to this situation, and I have to just be clear about the direction for our team and how we are going about with working in our attempt to be collaborative with our community partners. And as my colleague from Macomb said, we need our partners, we need our providers, and we make every single attempt to work collaboratively with our partners. So there are some things that, in terms of directive, when we started this process, in terms of looking at things over the last few years, I made a point of telling our team we will not be disparaging against our providers. And so that is challenging when we hear things that aren't necessarily accurate or viewed differently. So with this transition plan, honestly, it started years ago, and we started in terms of responding to needs that we saw that were unmet. So if you look at some of the programs and services that we have in place, they're a result of better responding to the community needs, such as crisis intervention training, which we recently became a platinum certified county for. And it's with the help of our provider partners as well as the law enforcement community in which we can do that. The CORE, which are represented here tonight, which have been amazing. We started with one, and now we have at least 10 that are working throughout the county and working collaboratively with our providers in ensuring that people get connected instead of being taken to jail. The other things that I'll talk about have to do with may seem small, but really are big things that are part of the crisis continuum. So if you look at a continuum of care, you're looking at early intervention, treatment, prevention, and recovery. So we're looking at ways to fulfill that crisis continuum along with our partners. And we've done that over the last few years when you look at our school mental health navigators, our veterans navigators, and all of the programs that we're working together to support. And when you even look at our finances and you look at how we have funded providers and stabilization costs and things of that nature, we push out more dollars than we keep, okay? And that is very critical because we put people before profit. And that's important to know as we plan for the future. Of course, there's a lot of unknowns right now, and we are doing our best to keep people informed internally with our team, but also externally. And there's a lot of rumors, a lot of miscommunication, and a lot of unknown. But in knowing that, these are things that we started many years ago in terms of working towards where we are now. And so with the transition plan of those crisis services, it is a phased approach
There was never any attempt or any communication about coming in and taking over. It was always about collaboratively working together, and several attempts have been made to do that. And it's not gone as well as we expected. I'm sure not as well as Common Ground has expected, but there have been months where we have worked together to try to talk about how we move forward, even with contracting, with leasing and things of that nature. It's been bumpy. We have to admit it's been bumpy, but at no point did we not pay our provider. And when I learned that the one time that it was a delayed payment, Heather texted me, we responded immediately, and we found that what the issue was, there was a payment schedule for our fee-for-service providers, right? And there's a payment that for Common Ground and our other providers, they are not on fee-for-service, because we know we can't put a crisis program on a fee-for-service. So as soon as we clarified with our finance team, we immediately made sure that that payment was made. So we are about being transparent. We are about planning and working together. And I've been updating the board as much as we can, and then making sure the information is passed along. So we did release a press because we wanted to be clear about our intention and about the work we want to do together. And of course, change is difficult, and I know people think that's a cliche, and it's almost, it's out of respect that we know these things are difficult, but we also know that there are needs that need to be met. And one of the most simple forms of change that has to be met is customer service. And we have heard numerous times where this is an opportunity for us to make improvements. So I challenge people to go and visit our providers, to come into our building. We should have the simple courtesy of greeting one another, right? So these are the things I want to give an update, but I also have to clarify why we're making the changes we're making, why we're moving in the direction we're moving in. And we have heard from the community. We have our Citizens Advisory Council, our Recipient Rights Advisory Council, and we hear firsthand where things have been difficult. So we wanted to make sure that we're working with this in a phase so that we don't lose anybody in this transition. We wanted to make sure it was seamless for people and not something that people reacted to out of fear, right? We wanted to make sure that people who had that great experience, and we do have experience in providing crisis services, had an opportunity to continue and work with our team. So those things are still on the table. We are very, very much willing and able and want to work with our partners. We do. It's difficult when things are met with a response or a non-response. So again, we want to work with our providers. We want to open the lines of communication that are truly, truly collaborative among our teams. So with that said, my report is here, and we had a lot of great events. Of course, you know, it's hard to come back with some of the things that are really promoting all the work that we all do. Every single person in this room does to contribute and help people when you have a meeting such as this. But it has to happen, and we have to hear the different perspectives. We know there's a lot of change at the federal level, at the state level, and locally. But we're prepared to do these transitions as smoothly as possible in a way that does not cause harm to the people we serve. And that's first and foremost. And I have to advocate for my team here. They are working hard and tirelessly to get these things together. And like Janet said, we're not doing things perfectly. And when we find we make mistakes, we own up and we come here and we address it as quickly as possible. And some things are more challenging and take a little longer. And if we're taking longer, Pastor Jones, we hear you. We need to let people know, hey, we heard you. We're working on it. We'll get back to you. And so those are the things that we really push in our culture internally, and we hope it shows externally when we're meeting with the community. We have a lot of events and things that occur here, and it just demonstrates our commitment to working. We all live and work in this community as well. And so, again, we advocate for the people in this community. We advocate for our law enforcement partners who tell us what the concerns are. And we try to make their jobs easier. They're not social workers and psychologists, but they are open to working with us, and we've had good outcomes because of that. We reach and work very well with the county, and so the department, with the county health department, we open up with honor an urgent or a walk-in clinic. So those are the things that we're doing that are on the continuum that are part of this transition plan, and continuing to look for opportunities to expand access and enhance our crisis services, not just with Common Ground, but as a community as a whole. So I'll end with that, and I'm open to answering any questions you may have.
Okay. Anybody have any questions for Dana? I do. You did talk about the transition is a three-part transition, and the first part is transition of front of the house operations and along with the sober support unit. What kind of how is that progressing in terms of personnel and things of that nature? Because that's the first step.
Well, we are hiring. We have interviewed quite a few people, internal candidates to Common Ground as well as outside individuals, and we do want to give first options to the people who are there, and we don't want to disrupt Common Ground's day-to-day. And many people don't know, our access team is already present there every single day, and they work side by side with the Common Ground team. And many times we support them in ways when situations there's a true team approach. So you're not hearing about the positive things that happen when our teams are really working collaboratively together. And so we have hospital liaisons. So when somebody can't move out of a hospital ED, our team is there to help that person move to the next level and trying to figure out what are the barriers, what's going on when this person is not there. And some of the other opportunities that exist and align with the phase approach is really to make sure that we don't have any gaps. We don't want to lose anybody in this transition. And the other thing is, and this is very, very critical, we need a true mobile crisis team. And right now, it's not working as well as it should and could. And it's because of some limitations with staffing. We know there are challenges, but this has been years of trying to really address this concern. So this is something that we are looking at. And, you know, in essence, a lot of the programs that we have are providing that resource to the community. So we want to make sure that when we're doing this transition, we have prioritized those things that really need to be addressed now, and then the other things that can sort of phase in. Because we can't turn a switch off. It's not that, and we're not dismissing any of the historical success of Common Ground at all. We hope to continue our work together, and we know that they're doing other things, and so it's important that we work together on this. And so that phased approach really was our attempt to sit and talk and work on what does this look like? How do we share in this transition? And again, I think it's heated, of course, because change is hard. And so we're still committed to coming to the table and working through that.
Anyone else? Yeah, Chris. Yeah.
This is, one thing that keeps coming up is PIHP. Well, I want to make clear, the OCHN proposal that we passed as a board, we would not be the board members on the PIHP if that goes through, correct?
Correct.
We would just be a CMHSP board at that point if the RFP goes through.
That's correct. And here's the other piece of it, because it's still unclear what the decision will be made. We will still be a CMHSP. And so that means that we are responsible for ensuring there are crisis services. So whatever happens with the PIHP piece of that, there'll be potentially another board or a new board, because it has to be separated. But it is a sign that people don't often understand. We have this dual role, but we have firewalls in place that ensure that we're not crossing over. So there are firewalls in place that are our managed care arm as a PIHP, and then also our service delivery arm as a CMHSP. And we use a lot of letters, but yes.
Yes.
So we have to plan for the future, but again, I want to emphasize that this is not something
in response or result of this bid. This is something we've been planning over the last few years in terms of how do we improve that front desk, how do we make sure that we don't have any gaps in care and services. And we've put things around it, and we've developed a system team, a crisis intervention stress management or team, right? Trish is much better explaining that than I am, but we have these things that we put together because we saw a need in the community, and we wanted to address those needs, and that's our responsibility.
And kind of building on Mr. Cowan's question, just so I understand, what starts January 1st or 2nd?
January 1st is when we really start to hopefully put these things in place, and that would be if you go to Common Ground at the Resource and Crisis Center, where we share that front desk, we would transition to ensure that people are being screened, and then we could triage and make sure that people get the right service and support. Again, we want to make sure that nobody's turned away. We want to make sure that when people come there, they're greeted and they receive the services and supports that they should.
So are phone numbers changing on January? And these are very basic questions.
No. Phone numbers are not changing. As we move towards these type of things, we'll be announcing if we indeed change the phone numbers, what that looks like, in ample time before those things take place. So.
And does that require a contract with Common Ground for them to continue to provide those phone services on January 2nd?
Yes, because again, this is a phased approach, and we are going month to month on a contract. We have a fiscal year 26 contract, and at this point, we received a letter that they're not willing to sign that contract. So we're still working through those things, and Kalana, I believe, is online, but again, overall, we're continuing to work, and hopefully we can resolve those issues.
Any other questions for Dana?
Dr. Giles.
Oh, Dr. Giles, sorry. Thank you.
Oh, that's okay. I just have one question I thought about based on Chris's question. You said there's a contract in place to provide the services, and if it's not signed, then what's the outcome? Because my question is based on our role is community service. So what happens to those individuals that we're all concerned about if this contract is not signed?
Part of that contract says we have to have a 60-day notice. So we would have to get a 60-day notice from Common Ground if they indeed want to pursue a non-continuation of this work. So we're looking at those things, and we know, and based on past experience, if that happens, we have to be ready to respond. And so, again, if you're working along this transition plan and we're not coming together, right, we have to be ready. So we can't just not move forward. So in the event that they make that decision, we have to be ready to step in.
And are we currently staffed to do the walk-in portion that you're suggesting?
We're working on that now. I don't know the exact number. Kim, you want to come and talk about the hiring?
Flowers, Chief Clinical Officer. Okay, yeah, so we do have about, I want to say 8 or so folks already working toward those front office positions, right? So you need supervisors, and you need 24-hour staffing to receive anyone walking in. And I think the question was the front area, the assessment team, and then the SUD. So yeah, we are working currently, again, staffing for those positions, but also policies and procedures, safety issues in the facility, all the things that we need to do to ensure that when someone walks in the door, there is someone who is ready to receive them, welcoming and having the documentation and our systems are ready to receive that information as well. Okay? So we're in the process of doing all of that, working very feverishly to get that done. So I think someone said there were 27 positions that we have currently, and we're still interviewing vigorously and working to find the best persons that we can. Many of them who already have training in the area and want to continue to work in the area and want to come and work with us. Okay, so, good?
Anyone else for Dana? All right, thank you. Anything else to add on any other issue, or is that enough?
Nope, that's
Okay.
enough.
No, I saw your full report, so thank you.
Thank you.
All right. That brings us to board member comments, and I'll start. Adam?
I'd like to thank everyone for their comments and their concerns and passion tonight. It's a very important issue to bring to the forefront, and like everyone was saying, crisis services is a bedrock of importance in the network and the services we provide. So hopefully, I was heartened a bit by the talks of hopes for collaboration in the future. So I hope that truly comes to pass. And thank you to everyone tonight who had a hand in putting the agenda together as well. Have a good night.
Thank you. Chris?
Yesterday, I was talking to someone about being on this board, and I said the favorite thing about being on the board of the meetings was public comment, and I'll see if I feel that way tomorrow, but truly I will. I think the public comment is the most valuable thing as a board member to hear and to get that feedback with the organization and leadership. And so thank you, everyone. I will note that I think all of us are very confused with the RFP process and becoming what that might mean for us as OCHN because of these dual hats that we have historically worn. And I think there's some misconceptions about that I feel as a board member because, when this press release was issued on May 23rd that I know Mr. Sharon was quoted in, and at least one of the things that I came up with as a board member is our role, as our hat ongoing is going to be as the CMHSP board members. And when I look at our role as a CMHSP board member, I look at MCL 330-1206, which says Community Mental Health Service Program, purposes, services. That will be us. That's the only hat we will wear if the RFP goes through. And the purpose of a community mental health services program shall be to provide a comprehensive array of mental health services appropriate to conditions of individuals who are located within its geographic service area, regardless of an individual's ability to pay. The array of mental health services shall include, at a minimum, all the following. A, crisis stabilization and response, including a 24-hour, 7-day-per-week crisis emergency services that is prepared to respond to persons experiencing acute emotional, behavioral, or social dysfunctions, and the provisions of inpatient or other protective environment for treatment. And I read that just to let everybody in the room know that if that's the hat we're going to wear, I can't blame OCHN for looking and having to look, because of the RFP process, what that means for us. What does that mean to deliver? And I can't fault that being part of our strategy of whether or not we need to bring that in-house or not. I think it's just a natural part of this RFP process, which was not transparent itself, and us as a board having to respond. So I sympathize with OCHN on that. With that said, I spoke last week and don't think I need to rehash as far as my feelings on this. I'm not happy with how it's been handled. I do think when we cut a service provider of this as citizens of Oakland County appointed by the Board of Commissioners, that we owe it to the citizens of Board of Commissioners in our position to have a board vote on it. And I think we should do that. And I also, think we're owed a plan, and not just a press release. Thank you for answering some of my questions there, Dana, but, with very detailed as far as what's going on. And I haven't seen that as a board member, and I think we are owed that and then to understand the process and our fiduciary duty, as was mentioned. And I do think that is lacking. And so I would like to see this continued. I would like to see this come to a board vote, and that would certainly be my position. And that might be bring it in-house. I've told you, I'm supportive of us having a strategy, looking what us being as a CMHSP is, because one thing I know is the mental health code requires us to do this, and that's statutory. And that's one way I can ensure that all these important services that we all agree on are not privatized. And that is a hat I can wear here in Oakland County. But one thing I do need to hear this organization to hear, Dana, I need you to hear this, Tricia, I need to hear this. I said this time because what I've been seeing since I've been a board member is this feedback from the community that we're just not treating people well. And I don't know what level of this organization that is. And, you know, before I knew there was going to be a lot of feedback today, I was with my first grade son, who every day he goes to elementary school with the Blue Jay Way. And the Blue Jay Way is leading with kindness, respect, and empathy at every space and every day. And I just think, as an organization, we need to take a step back, and whether it's with negotiations on these contracts or whatever, it doesn't cost us a Medicaid dollar, not a single Medicaid dollar, to lead with kindness, respect, and empathy in every space and every way. And I hope we do that ongoing. Thank you.
Yvette?
Thank you to all of you who have come out on tonight and shared your input.
Dr. Giles? That was, yeah.
Laughter is good for the soul sometimes. I'm sorry. I thought she was going to say more. I also want to say thank you to everyone that provided comments, feedback. I was sitting here writing down different things I heard from everyone. And I said, we all should understand when you're in the business of human service, it's not easy. It's always difficult because we as individuals are very complex. And what we try to do is group services for individuals that we already know are very complex. So when you do that, you get complaints, right? You don't always hear positive feedback for the work that you do. And so this spreads to everyone. So those employees at OCHN, Mike, thank you. Those employees with Common Ground, thank you, because it's great that some of you came up and said you've heard positive feedback and you're worried about what's going to happen to those individuals if you aren't there for them. So it's great that you get that positive feedback, but we always have to remember we're dealing with a very complex system. Human service, and if our goal is community service, to service individuals in need, in particular with mental health conditions, then I asked myself when I heard things like Common Ground is ready for change, I heard a fair transition agreement, and I resonated on fair. I said fair for who? Fair for everyone, right? So that means coming back to the table, being ready to reconcile, right? Maybe initially things didn't go well. People were upset. I was happy, as Mr. Furman pointed out, to hear that OCHN is ready to collaborate. They're ready to come back to the table and collaborate. I'd love to hear that from Common Ground because you're right, you have experience. And if our goal is community service, human service, then we should be able to come together with that goal in mind, no matter what, right? And then the last thing that I heard, or one other thing that I heard I wanted to point out was this would be part of one of many solutions. It's not the solution, right? No one's perfect, but it's part of many solutions. So this transition, I have to get her name right. Who said this? Ms. Smith, CEO for Macomb. One of many solutions. And I believe part of it is accepting that if we all have the same goal in mind, we should be able to come together for the people that we're so concerned about. So again, thanks to everyone, all employees who are working with humans as we do. It's not easy, and change is even more difficult and painful. So thank you all.
Dr. Guadalupe?
It's hard to follow, Dr. Giles. Sorry. But, no, just thank you to everyone that came out to share your stories, your passion. And again, it is important that we have a transition plan, that there's collaboration, because we need to be there for those that we're serving, especially in times of crisis.
Thank you. Pastor Jones?
Well, I spent some time writing some things down, and this has been a big issue. Everybody should know that. Where Common Ground is, where OCHN is. And over these last few weeks, talking to so many of you, my friend Eric, is Matt still here? Talk with Matt, different persons. And I've also talked with our board. I've also talked with our board. Talk about where we are, what are we doing? What is your impression and what have you? And, I think we're tussling with this. It's not easy for change to happen. And especially when you say who's impacted positively or negatively. You've heard me tonight, issues, response time, follow-up, transition, payroll delay, transparency, coverage. And that's what I've heard over these last few weeks, these last few months. That's why I raised that issue. I raised the issue of getting back, talking to people, bringing it to light. Because if you don't say anything, then nothing gets done. If you live with it, you live with it. But one of the things we've attempted to do, and I've said it to the persons that are part of OCHN, I think that we have one of the greatest groups of people out there. Does not mean that other groups don't have it either. But really what has to happen, at the end of the day, you have to say, what did I do? What did I achieve? How did I work? This issue of mental health, emotional health, physical health, and all of that, it's one of the biggest things that all of us are dealing with. All of us are dealing with it. Many of us in different ways, impacting our lives, impacting what we do, how we do. And so it is a big concern to all of us. And this particular move is not easy. And so we should be able to collaborate. My partner down at the end said, hey, we really need to talk about it. I challenge our board. We need to talk about it. But you can't come to an agreement. You can't come to an agreement if you don't talk. If you don't say, let's discuss this. That's why I talk about getting back, okay? Getting back to someone. Somebody call you, get back with them. You can agree to disagree. But you really need to communicate with each other. There are some things that are within our power and some things that are not. And we are at one of the biggest crossroads ever. I think all of us know that. All of us are concerned with what's happening with Medicare, Medicaid, and all of those things. The only way we're going to resolve it is to sit down and talk about it, because we know there are changes. Change will be impacted and will impact each one of our lives. I appreciate your discussions today. I appreciate it. Because at the end of the day, I have to sit down and say, okay, what did I hear? What were they saying? How were they speaking? And it's the same thing that we would do as a board. The same thing. Whether we call a board meeting to vote, or whether we say, let's look at what we've got. But one of the things that has to happen, we have to sit down and talk about it. And you got to separate some of the emotion. You have to separate some of the emotion, which is very difficult, and say what is right for the people that we serve. What is right for the people that we serve? I will be honest with you and say I'm parochial because I like what OCHN does. The outreach that we're doing. The more we're trying to reach to different people. I would tell you that. But I also know there are other alternatives. There are other alternatives. But the only way you resolve it is to sit down and talk. And I'm hearing, we tried to talk this, tried to talk that. You know, I heard part of that tonight. Question is, let's sit down and talk, and let's resolve it, because there has to be a solution between where we are. There has to be a solution. Where are we? Because all of us are being impacted. All of us. So I say to my friends at Common Ground, as I say to our board here, at the end of the day, we have to sit down and talk and come to whatever agreement we have to come to. And that's how I'm going to end it this evening.
Thank you.
That's how I'm going to end it. Thank you.
Thank you. John?
I would agree with Dr. Giles and Pastor Jones. We're dealing with people at every level in each of these situations. And, 5 years ago, I was on the other side of the aisle, right? Transportation. So why did I end up with a big mouth on the board? Because the provider basically said, well, we're done. Okay, that was it. Can't drive them to the farm anymore. No real reason. No explanation. Just, it doesn't work for our logistics. So I would encourage folks to stay vocal, stay active, but what Pastor Jones said, you got to talk about it. Showing up on occasion and being upset, as a parent, I got news for you. I'm upset 6 days out of 7. Dealing with big providers and small providers. Sometimes it takes a month to hear back. Okay, that's not OCHN. That's the front line. My daughter's in the industry as well. So some of this has got to go back to Lansing. I know you think that's a cop-out, but by the time it trickles down, I'm glad we can talk with Macomb. I wish Dewin were here. I wish we met with them more frequently. First year on the board during COVID, we were all in it together. 2 years out of COVID, everybody's going to their legislator and their lobbyist separately. I got a lot of friends connected with Autism Alliance. What just happened there? All of a sudden, after 4 years, we don't need navigators? How? In this state, where we're going to spend billions on data centers, we don't need navigators? So all you elected officials out there, think about what that says to everybody. It's just like y'all, I live it with twins and a daughter who works in the business.
Thank you. Yes, I want to thank everyone who came out. I certainly many passionate statements, but at the end of the day, as has been stated, we do have to reach agreement. We have had a public vote. We voted on a policy in our plan, and now that policy is being executed by our CEO. So that has occurred. That was done in public, and that's the only way we can work, because we are a policy-making board. That is our role. That is our mission. And I do want to point out one other small thing, because our team here worked very hard on transportation. When Dana approached us about transportation, John and I thought maybe she was losing it, because why do you want to own such a broken system? And it was broken. There were rates all over the place. There was inconsistent service. And it's worked. It took a lot of hard work. So we're not afraid of taking on hard challenges. Again, I want to thank everyone for coming out this evening, and we now stand adjourned.